Welcome to the Deep Dive. Today we're tackling a really big one, the principles of cancer treatment. I mean, it's a field that's just incredibly complex, constantly evolving.
Right, new discoveries all the time. It's hard to keep up.
Exactly. And the sheer amount of information can feel, well, overwhelming. So our mission today is to kind of cut through that. We're going deep into a foundational source, Chapter 73, of a really key text on cancer treatment.
A very comprehensive chapter.
And we want to unpack the principles it lays out, aiming for what you might call an elite professional level of understanding. We'll cover everything from the first hint of suspicion through diagnosis, treatment types, all those challenges, the whole journey.
And the source really provides a great structure for that, a framework. It shows how everything connects diagnosis, staging, treatment goals, the different therapies.
It helps you build that mental model, right? See how the pieces fit.
Precisely. It helps make sense of the whole landscape.
Fantastic.
Yeah.
Okay, so let's jump in. Let's unpack these principles, starting right at the beginning, where the source begins with the very first considerations of cancer.
Okay, sounds good. So yeah, dealing with cancer isn't just about the treatment itself. It's really a spectrum. It starts way earlier, sometimes with screening,
Like mammograms, colonoscopies, looking for cancer before there are any symptoms.
Exactly. Proactive screening. But often the journey starts differently. It starts because someone has symptoms, persistent signs or symptoms, that make you or their doctor suspicious.
And the source makes a really critical point here, especially for anyone in healthcare.
Yeah.
It's about vigilance, isn't it? Thinking about cancer, even if it seems unlikely.
Absolutely critical, because even if a symptom, let's say a persistent cough or losing weight without trying, even if it's statistically more likely to be something else.
Nothing benign.
Right. The consequences of missing an early-stage cancer, one that might be curable, are just so significant. You have to keep cancer in mind, even if the odds seem low initially.
That vigilance sounds key. So where does the evidence for a potential tumor usually come from?
Well, a few places. The physical exam is fundamental, just, feeling for things. An enlarged lymph node could be lymphoma, or maybe metastasis from somewhere else, or finding a lump in the breast or the abdomen.
Then imaging, of course. That's huge.
Huge. X-rays, CT scans, ultrasound, PET, MRI. These let us see inside look for masses or suspicious areas.
And for some organs?
Like the gut.
For hollow organs, esophagus, stomach, colon endoscopy lets you get a direct look inside with a camera.
Okay, so whether it's exam, imaging, endoscopy, you find something suspicious. What's next? How do you confirm it?
Right. The next step, almost always, is getting a definitive diagnosis.
Yeah.
And that, as the source makes crystal clear, overwhelmingly relies on getting a tissue sample, a biopsy.
You need tissue.
You absolutely need tissue in the vast majority of situations. A pathologist has to look at it under the microscope. That's the gold standard for confirmation.
Are there exceptions when you might skip a biopsy? Very rare exceptions. The source mentions things like maybe a tumor in the brainstem where the imaging is completely typical and doing a biopsy would be extremely dangerous. In those highly selected cases, yeah, you might treat based on clinical and imaging findings alone.
But that's really the outlier.
Totally the outlier. For almost everything else, you need that pathological confirmation.
And getting that tissue. It's not just about looking at cell shapes anymore, is it?
Oh, far from it. I mean, yes, the basic histology under the microscope is the starting point. Is it cancer? What type is it? Adenocarcinoma, squamous cell, whatever. But that biopsy tissue is like a treasure trove now.
How so?
Because it lets you do all sorts of crucial molecular studies, immunohistochemistry to look for specific proteins, cytogenetics for chromosome changes, sequencing for gene mutations.
All from that same small piece of tissue.
Exactly.
Yeah.
Defining those genetic abnormalities, those protein expression patterns, that information is absolutely fundamental. It's what allows for tailoring treatment, for precision medicine.
Okay, so you need a biopsy. How do you actually get the tissue? The source talks about different techniques.
Yeah, there's kind of a hierarchy, depending on how much tissue you need and how invasive you can be. Ideally, if it's possible, you do an excisional biopsy.
Meaning you take the whole thing out.
Exactly. The surgeon removes the entire suspected mass, hopefully with a little bit of normal tissue around it as a margin.
That sounds optimal. You might even cure it right there.
In some situations, yes. But if taking the whole thing out isn't practical, maybe it's too big or too close to something vital, the next best option is an incisional biopsy.
So just taking a piece.
Right. The surgeon takes a wedge, a portion of the tumor. They try to get a representative sample, kind of a cross-section, to minimize the chance of missing the cancerous part if it's mixed.
But cutting into a tumor, does that carry risks?
Well, it needs careful planning. The source notes there's a theoretical risk, of potentially seeding tumor cells locally when you cut into it. So it's a consideration. It's often necessary, but requires careful surgical technique.
And then the less invasive methods involve needles.
Correct. You have core needle biopsy that uses a slightly larger needle to get a small cylinder, a core of tissue. Less tissue than an incisional, but often enough for the diagnosis and those all-important molecular tests.
And even less invasive
Is fine needle aspiration, or FNA. A very thin needle just sucks out a suspension of cells.
So not solid tissue, just loose cells.
That's the key difference. Now, if an FNA comes back positive for cancer cells, that can be enough. Enough to maybe start systemic therapy or plan a bigger surgery.
But what if it's negative?
That's the crucial caveat the source points out. A negative FNA does not reliably rule out cancer. You might have just missed the malignant cells, sampled a benign area, or maybe didn't get enough cells.
So a positive FNA is useful, but a negative one doesn't give you the all clear.
Exactly. If you still have high suspicion, you'd need to follow up with a core biopsy or something more definitive. It's an important distinction.
Makes sense. Okay, so diagnosis confirmed. The next big step is staging. Why is that so essential?
Staging is critical because it tells you the extent of the cancer. How big is the primary tumor? Has it spread to nearby lymph nodes? Has it metastasized to distant organs? This information directly dictates your initial treatment strategy.
Like whether you can aim for a cure with just local treatment.
Precisely. Or if it's already spread, meaning you'll likely need systemic therapy that travels throughout the body.
And the source distinguishes between clinical and pathologic staging. What's that about?
So clinical staging is your assessment before definitive treatment.
Yeah.
It's based on the physical exam, those imaging scans we talked about. Basically non-invasive or minimally invasive information. It's your best estimate of the extent.
And pathologic.
Pathologic staging comes from examining tissue removed during surgery. So when surgeons remove lymph nodes during breast cancer surgery, for example, and the pathologist confirms cancer cells are in those nodes, that's pathologic confirmation of spread, it's generally more accurate because you're looking directly at the tissue.
Got it. And the system used for most solid tumors is TNM.
Yeah, TNM is the universal language. T is for tumor size and how far it's invaded locally. N is for nodes, lymph node involvement, how many where. And M is for metastasis, whether it's spread to distant sites.
TNM, tumor, nodes, metastasis. Simple enough.
The basics are. Then these T, N, and M values are grouped together into overall stages, usually stage I, 2, 3, and 4.
Why group them?
Because decades of data show that patients with similar T and M combinations tend to have similar outcomes, similar long-term survival when they get the appropriate treatment for that stage. It helps predict prognosis and guide therapy.
So stage I is generally good news, relatively speaking.
Generally, yes. Stage I usually means a small tumor, like T1, no or maybe minimal node involvement, N0 or N1, and no distant spread, M0. These are typically cancers you can treat, often cure, with local therapies like surgery or radiation.
And stage 4 is the other end of the spectrum.
Right. Stage 4 means the cancer has metastasized to distant organs or it's so locally advanced it can't be removed surgically. For most cancers, stage 4 means the goal shifts to palliation, controlling the disease, managing symptoms, maintaining quality of life.
But not always incurable.
Not always. There are important exceptions, the source notes. Some cancers, even when metastatic, are highly sensitive to systemic treatments like chemotherapy or immunotherapy. Certain lymphomas, testicular cancer, for instance, cure can still be possible in those cases.
Does TNM work for everything?
No, it has limitations. It doesn't really apply to diseases like leukemia, which start in the bone marrow and are systemic from the get-go. And for brain tumors, factors like the tumor's specific type, its grade, and how much could be surgically removed are often more prognostically important than a TNM stage.
Okay. Diagnosis and staging set the scene. Now, treatment planning. What's the ultimate goal?
The primary goal always is to eradicate the cancer completely if that's feasible. Cure.
And if cure isn't possible?
Then the goal shifts to palliation, which means relieving symptoms, preserving or improving quality of life, and often trying to extend life as long as possible, provided the treatment itself isn't too burdensome.
That balance between benefit and toxicity seems crucial.
Absolutely. If you're going for cure, you and the patient might accept pretty significant side effects because the potential gain is huge. But for palliative treatment, minimizing toxicity is key. You don't want the cure to be worse than the disease, so to speak.
Makes perfect sense. The treatments themselves fall into two broad buckets.
Yeah, local treatments and systemic treatments. Local treatments target the cancer where it is and maybe the immediate surrounding area. That's surgery, radiation therapy, and also ablative techniques using heat like radiofrequency ablation or extreme cold like cryosurgery to destroy the tumor.
And systemic treatments go everywhere.
They travel through the bloodstream, reaching cancer cells potentially anywhere in the body. This includes chemotherapy, which is a really broad term now.
Right, includes traditional drugs, hormones, targeted therapies.
Exactly. And it also includes biologic therapies, which is where immunotherapy, CRT cells, and antibody treatments fit in.
And you often use these together.
Very often. Modern cancer care is almost always multidisciplinary. You have surgeons, radiation oncologists, medical oncologists, pathologists, radiologists, all working as a team to figure out the best combination and sequence of treatments for that individual patient.
Before we get into the specifics of those treatments, the source discusses tumor growth. Why is that important to understand?
Well, because how tumors grow influences how well treatments work, especially systemic ones that often target dividing cells. Understanding the kinetics helps explain why early detection is so vital and why some strategies work better at different disease stages.
Tumors aren't just uniform balls of dividing cells.
No, not at all. Like normal tissues, they have cells that are actively dividing the growth fraction, but also a population of non-cycling cells. And critically, they contain cancer stem cells, which are thought to be capable of repopulating the entire tumor.
And there's this model called Gompertzian growth.
Right. Figure 73:1 illustrates it. It's a model suggesting that solid tumors don't grow at a constant exponential rate. The percentage of dividing cells, the growth fraction, is actually highest when the tumor is tiny, microscopic, way below detection level.
So it's growing fastest when we can't even see it.
In terms of the rate of cell division, yes, according to this model. As the tumor gets bigger, the growth fraction tends to decrease. By the time a tumor is clinically detectable, maybe a centimeter across, which is about 109 cells.
A billion cells.
Yeah, a billion cells. At that point, for many solid tumors, maybe only 1 to 4% of the cells are actively dividing at any given time.
Why does it slow down relative to its size?
The model suggests the limitations kick in maybe nutrient supply, oxygen availability, buildup of waste products, or even host immune responses. The tumor's growth rate peaks when it's roughly a third of its maximum possible size, and then the rate of increase slows.
And the scale is staggering. Detectable around 109 cells, but potentially lethal around 10 to 12.
That's a 1,000-fold difference, about a kilogram of tumor mass. It really highlights the challenge. By the time we find it, it's often past its most rapid growth phase. The source also mentions angiogenesis of the tumor, recruiting its own blood supply as crucial for enabling this growth beyond a tiny size.
And angiogenesis itself is a treatment target.
It is indeed. Anti-angiogenic drugs are part of the arsenal.
Okay, so growth patterns matter. This leads perfectly into tailoring treatment based on the specific tumor. You mentioned molecular studies earlier.
Absolutely essential now. This is where that biopsy tissue analysis really shines. We're looking for specific molecular features, gene mutations, abnormal protein levels, gene expression signatures. This information is used to personalize therapy, to choose treatments most likely to work for that specific tumor. It's the core of precision oncology.
Can you give some examples of these crucial markers?
Sure, the source lists quite a few. For any solid tumor now, testing for things like tumor mutational burden, TMB, microsatellite instability, MSI, and the status of DNA repair pathways like homologous recombination. That's becoming standard.
Why those specifically?
Because tumors with high TMB or MSI often have problems fixing DNA damage, making them potentially more visible to the immune system and more sensitive to immunotherapy, specifically checkpoint inhibitors. This led to those tissue-agnostic approvals, drugs approved based on the molecular feature, not the tumor location.
A huge shift. Treating the mutation, not just the organ.
A fundamental shift. Then, for specific cancers. In breast cancer, BRCA12 mutations guide PIRP inhibitor use. Estrogen-progesterone receptor status dictates hormonal therapy. HER2 protein overexpression is targeted by drugs like trastuzumab. PI3KA mutations are another target.
So multiple targets just within breast cancer.
Definitely. For non-small cell lung cancer, NSCLC, especially the non-squamous type, EGFR mutations, ALK fusions, BRAF V600E mutations are key targets for specific inhibitors. PD-L1 expression level helps predict response to immunotherapy. In metastatic colon cancer, KRAS and BRAF mutations tell you whether certain EGFR inhibitors are likely to work. G-chase tumors almost always have KIT mutations, making them responsive to drugs like imatinib. Melanoma frequently has BRAF mutations, guiding the use of BRAF and MEK inhibitor combinations. Pancreatic and prostate cancers can have BRCA mutations, opening the door for PRAAP inhibitors there too. Thyroid cancer can have RET alterations, now targetable. Brain tumors, gliomas, are classified and treated based on things like IDH mutations or 1p19q co-deletion, and for blood cancers, leukemias, lymphomas, it's even more complex. Cytogenetics, flow cytometry, specific translocations like BCR-ABL in CML, mutations like FLT3 in AML, protein markers like CD20 on lymphomas, these are all critical for diagnosis, prognosis, and choosing therapy.
Wow, that list really hammers home how individualized treatment planning has become. It's all about finding those specific vulnerabilities.
It absolutely is. And as the source knows, understanding these cancer-specific molecules also gives us hope for developing better, more sensitive early detection methods down the line.
Okay, we've got the diagnosis, the stage, growth patterns, molecular targets. Now let's really dig into the treatment, starting with the local treatments. Radiation therapy is a big one.
A cornerstone, definitely. Radiation uses high-energy beams, X-rays, gamma rays, particles like protons or electrons to damage the DNA of cancer cells, stopping them from dividing and killing them.
How is the dose measured?
The standard unit now is the gray, symbol G. It represents the amount of energy absorbed per kilogram of tissue. You'll also hear centigray, CGI 100, CGI equals 1G. The older unit, the rad, is basically the same as a centigray.
And delivering the right dose isn't just about the total amount given.
No, the effect depends critically on three things: the total absorbed dose, the number of fractions, meaning how many separate treatment sessions it's divided into, and the total time over which the treatment is given.
Why break it up into fractions? Why not give it all at once?
Fractionation is key. Giving smaller doses daily, typically Monday to Friday, allows normal tissues in the radiation field some time to repair the sublethal damage between treatments. Cancer cells, often having defective repair mechanisms, tend to accumulate damage more effectively.
So it exploits a difference between normal and cancer cells.
Exactly. It widens that therapeutic window. Also, rapidly dividing cells are generally more sensitive than non-dividing cells, and the cell's ability to repair DNA damage plays a big role in sensitivity.
Does the type of radiation energy matter? Like X-rays versus protons?
Oh, hugely. It determines how deep the radiation penetrates and how much it scatters sideways. Older, lower energy X-rays scatter more, potentially damaging adjacent normal tissues. Modern high energy or megavoltage radiation goes deeper with less scatter, and it actually spares the skin surface somewhat.
And protons are even more precise.
Yes, protons have a unique physical property where they deposit most of their energy at a specific depth, called the Bragg peak, with very little dose beyond that point. This allows for highly conformal treatment, shaping the high-dose region very tightly around the tumor and minimizing dose to surrounding critical structures.
How is the radiation actually delivered to the patient?
Most commonly, it's teletherapy, meaning therapy from a distance. The radiation source, like a linear accelerator producing X-rays or protons, is outside the body, and beams are aimed precisely at the tumor.
But sometimes it's delivered from inside.
Right, that's brachytherapy. Small encapsulated radioactive sources are placed directly into or very close to the tumor tissue. And then there's systemic radiation therapy, where radioactive isotopes are given, usually IV, and they travel through the body, sometimes targeting specific tissues.
You mentioned electron beams, too.
Yes. Electrons are particles with shallow penetration, so they're useful for treating superficial targets like skin cancers.
Can drugs boost radiation's effect?
Yes, certain drugs act as radiosensitizers. They make cancer cells more vulnerable to radiation damage. The source mentions drugs that get incorporated into DNA, or agents like cisplatin, which is often given concurrently with radiation for cancers like head and neck, cervical, and rectal cancer to improve outcomes.
But radiation isn't without side effects.
Definitely not. Even though it's targeted locally, it can cause systemic symptoms like fatigue, nausea, loss of appetite, possibly due to inflammatory responses. And local toxicity depends heavily on which tissues are in the beam.
Which tissues are most sensitive?
Bone marrow, testes, ovaries are highly sensitive, usually wiped out if they're directly in the field. Organs with rapid cell turnover, like the lining of the mouth and gut, causing mucositis, or the skin, causing redness, peeling, are also quite sensitive acutely. More resistant tissues are those with slower turnover, like muscle or nerves, but even in those, the blood vessels supplying them can be damaged over time.
And acute side effects usually happen during or right after treatment.
Yes, things like mucositis, skin reactions, maybe some marrow suppression if a large volume is treated. Sometimes these can be managed by taking a short break from treatment to allow healing.
What about other local treatments besides radiation?
The source mentions several. Endoscopy can be used therapeutically, like placing stents to relieve blockages in the GI tract or bile ducts, mostly for palliation. Radiofrequency ablation, RFA, uses focused heat from microwave energy to basically cook and destroy tumor tissue, often used for liver mets or other localized problems when surgery isn't feasible.
And the opposite, using cold.
That's cryosurgery, using extreme cold to freeze and kill tumor cells. Then there's photodynamic therapy or phototherapy. Patients get a drug that preferentially accumulates in cancer cells, and then you shine a specific wavelength of light on the tumor, activating the drug to produce toxic free radicals that kill the cells. It's used for certain skin cancers or cancers lining hollow organs.
Sounds quite targeted.
It can be and can provide good palliation for locally advanced disease sometimes. Finally, there's local infusion delivering chemotherapy or radioactive particles directly to the tumor area via a catheter placed in an artery supplying it, aiming for high local concentration with less systemic exposure.
Okay, that's a good rundown of local strategies. Now let's shift gears to systemic treatments therapies that work throughout the body. The historical perspective is quite interesting.
It really is. It shows how different observations sort of coalesced over time. You had Paul Ehrlich back in the early 1900s with his idea of magic bullets, based on how dyes selectively stain tissues. Then the toxic effects of mustard gas on bone marrow in World War I gave the idea that maybe similar chemicals could target rapidly dividing leukemia cells.
And the hormone connection.
Observing that removing ovaries could shrink breast tumors was huge. It showed that the body's own substances, hormones, could influence tumor growth, paving the way for endocrine therapies.
And immunotherapy also has surprisingly old roots.
Yes, there were anecdotal reports, even in the late 19th century, of tumors shrinking after patients got bacterial infections. That hinted the immune system could fight cancer. Early attempts using bacterial extracts, vaccines, even transferring immune cells back in the 80s, they had limited success overall, but achieved durable results in a very small number of patients, providing the rationale for the sophisticated immunotherapies we have today.
So these historical threads lead to the three main categories of systemic therapy we use now.
Exactly. The source neatly groups them into 1. Cytotoxic chemotherapy agents, 2. Cancer molecular target therapies, and 3. Cancer biologic therapies.
Let's quickly define those again. Cytotoxics are.
These are the classic chemo drugs, usually small molecules. They generally work by damaging DNA or interfering with cell division. They kill rapidly dividing cells, both cancerous and normal, which explains their common side effect profile: hair loss, low blood counts, nausea.
Targeted therapies.
Also, often small molecules, but these are designed, rationally designed usually, to hit a specific molecular target, a protein, often a kinase, that's known to be crucial for that particular cancer cell's growth or survival. The idea is to be more precise, hitting the cancer's Achilles heel.
And biologics.
These tend to be larger molecules like antibodies or even living therapies like cells or viruses. They often work by interacting with the immune system, either targeting cancer cells for immune attack or, more commonly now, modulating the patient's own immune cells to make them more effective against the cancer. Think immunotherapy.
What are the overarching principles for using these systemic drugs?
A really key concept is the therapeutic index. That's the gap between the dose needed for an anti-cancer effect and the dose that causes unacceptable toxicity. You want a wide index.
Easier to use safely.
Right. Cytotoxic drugs often have narrow indices because they hit normal dividing cells too. Targeted agents, while more specific, can still cause toxicity if the target exists in normal tissues or if they have off-target effects. Biologics can cause immune-related side effects if the immune system gets overstimulated or misdirected.
So finding that right balance, effective dose with tolerable side effects is always the goal.
Always. It's central to drug development and clinical practice. The source also makes a point about biologics. Their effect often depends on the tumor cell expressing the target, or the host's immune system being engaged. Their best dose might be the one that achieves the optimal biological effect, not necessarily the highest dose you can tolerate, which is different from traditional chemo thinking.
How do these drugs actually make cancer cells die?
The main mechanisms, as shown in figure 73-3, involve triggering cell death pathways, usually apoptosis, that's programmed cell death. The drug interacts with its target, which sets off signaling cascades inside the cell that ultimately activate enzymes to dismantle the cell. Some agents can also push cancer cells towards differentiation, making them behave more like normal cells.
Okay, so these drugs look promising in the lab. How do they get into clinical use? Through clinical trials, right?
Correct. It's a structured, multi-phase process. Phase 1 is the first time in humans. The main goals are safety, finding a dose range that's tolerable, and looking for any early signs of activity.
Dose finding and safety.
Primarily, if it looks safe and potentially active, it moves to Phase 2. Phase 2 trials focus more on efficacy. How well does it work against specific cancer types? This is where you really start quantifying the anti-tumor effect. For targeted drugs, you might focus on patients whose tumors have the specific molecular target.
And phase 3 is the definitive test.
Usually, yes. Phase 3 trials are typically large, randomized controlled trials. The new drug is compared head-to-head against the current standard of care, or sometimes a placebo. The key endpoint is often proving the new drug improves survival or delays cancer progression. Positive Phase 3 results are generally needed for FDA approval.
How do they measure if a drug is working in these trials?
They use standardized response criteria, usually based on imaging, like CT scans, measuring tumor size changes. Progression means significant growth or new spots. Partial response means significant shrinkage. Stable disease is in between. Complete response means all detectable tumor is gone.
But you mentioned immunotherapy response can be different.
That's an important nuance. With immunotherapy, you can sometimes see tumors initially swell due to immune cell infiltration inflammation before they shrink. It's called pseudoprogression. So you don't want to stop the drug too early just based on size increase if the patient is otherwise doing well. Assessment is more complex.
How are side effects tracked and reported?
Using a standard grading system, usually grades 1 through 5. Grade 1 is mild, no treatment needed. Grade 2 might need symptomatic treatment. Grade 3 is severe, potentially serious. Grade 4 is life-threatening. Grade 5 means the toxicity resulted in death. Quality of life assessment is also increasingly incorporated into trials now.
The source mentions different ways to visualize trial data. Waterfall plots, swimmer plots.
Yeah, they're useful visual tools. Waterfall plots show the best tumor response for each patient. You can quickly see how many responded and by how much. Swimmer plots track individual patients over time, showing how long they stayed on treatment and the response duration, great for highlighting long-term benefit. Kaplan-Meier curves are the standard for showing survival differences between groups in Phase 3 trials.
And developing targeted agents might look a bit different.
It can. Phase 1 might enroll patients known to have the target. You also do pharmacodynamic studies tests to see if the drug is actually hitting the target in the patient's tumor cells. A targeted drug can fail either because it doesn't hit the target well enough or because hitting the target, even effectively, just doesn't stop the cancer, meaning the target wasn't as critical as thought.
Which connects back to those tissue-agnostic approvals based on molecular features.
Exactly. It reflects the growing understanding that the underlying molecular driver can be more important than the tissue of origin for some therapies, especially immunotherapies targeting DNA repair defects.
Okay, putting it all together, how are these systemic therapies actually deployed in the clinic? What are the strategies?
My ultimate goal is always a valuable clinical outcome: shrinking tumors, improving survival, delaying progression, making patients feel better. The source provides a really useful table 73-3, categorizing cancers based on their responsiveness and the role of chemotherapy.
And amazingly, some advanced metastatic cancers can be cured with chemotherapy alone.
Yes, it's crucial to remember that. Certain leukemias and lymphomas, testicular cancer, gestational trophoblastic disease, some pediatric cancers, even small cell lung cancer and ovarian cancer. In some cases, chemotherapy offers a real chance of cure, even when widespread.
What about chemo combined with radiation? Curative potential there too.
Definitely. Combining chemo and radiation is standard, often curative, for many locally advanced cancers: squamous cancers of the head, neck, or anus, breast cancer, cervical cancer, stage 3 lung cancer.
And chemo used after surgery. Adjuvant therapy.
Right. Adjuvant chemo aims to mop up any microscopic cells left behind after surgery. It's proven to improve cure rates in breast cancer, colorectal cancer, osteosarcoma, and others.
And neoadjuvant is before surgery.
Correct. Giving chemo before surgery can shrink the tumor, making it easier to remove completely, potentially allowing for less expensive surgery, or improving the odds that subsequent local therapy will work.
There's also high-dose chemo.
High-dose chemotherapy with stem cell rescue is an intensive approach. You give doses high enough to wipe out the bone marrow, hoping for a greater anti-cancer effect, then rescue the patient with their own stored stem cells, autologous, or donor cells, allogeneic. It's used in settings like relapsed lymphoma or myeloma.
But for many advanced cancers, cure isn't realistic, yet treatment still helps.
Absolutely. This is palliative therapy. Even if you can't cure the cancer, systemic treatment can often shrink tumors, relieve pain or other symptoms, maintain function, improve quality of life, and extend survival. The source lists many cancers where this is the case: bladder, stomach, kidney, certain lymphomas, myeloma. The list is long. The benefit is judged by clinical trial data.
And unfortunately, some cancers remain very difficult to treat effectively in advanced stages.
Yes, sadly. Pancreatic cancer, biliary cancers, some types of lung, prostate, melanoma, these remain major challenges, though progress is being made, often through targeted and immunotherapies now.
When considering palliative treatment, what are the key factors?
Patients need to understand the goals: symptom control, quality of life, maybe extending life but not cure. Good supportive care is essential. And the patient's overall health, their performance status, is critical.
That's measured by scales like ECOG.
Yeah, the ECOG scale goes from 0, fully active, to 4, bedridden. 5 is death. Generally, patients who are ECOG 0, 1, or maybe 2, ambulatory, capable of self-care, are better candidates for palliative chemo. For patients with poor performance status, 3 or 4, chemo is often too toxic unless their poor function is directly due to a very rapidly responsive tumor. Assessing overall fitness, especially in older patients, is important.
Okay, let's dive into biologic therapy now, using figure 73-4 as a guide. It's about harnessing biology, especially the immune system.
Exactly. It's about manipulating the host-tumor interaction in the patient's favor. And often, these therapies need the tumor cells to express a target or the patient's immune system to get engaged.
The figure shows anti-tumor cell antibodies as one strategy.
Right. These are antibodies designed to stick specifically to proteins, antigens, on the surface of cancer cells. They can work by directly blocking growth signals or by acting like flags to attract immune cells to kill the cancer cell.
Like rituximab for lymphoma or trastuzumab for breast cancer.
Perfect examples. Rituximab hits CD20 on B cells, triggering their destruction. Trastuzumab hits HER2, blocking its signaling and calling in the immune system. Others target EGFR, CD52, etc. They've been game changers.
But they have their own side effects.
They do. Infusion reactions are common initially. Some can suppress the immune system, increasing infection risk or reactivating old viruses. Anti-EGFR antibodies cause a characteristic rash. Trastuzumab can affect the heart.
Then there are antibody conjugates, antibodies carrying a payload.
A very smart approach. You attach a potent toxin chemodrug, radioactive particle, to an antibody that targets a tumor antigen. The antibody delivers the warhead preferentially to the cancer cell.
Like a guided missile.
Pretty much. Examples include TDM1, trastuzumab emtansine for HER2 plus breast cancer, or brentuximab vedotin for CD30 plus lymphoma. The side effects often relate to the payload toxicity, but hopefully more targeted.
Okay, next category. Immunoregulatory cell-targeting antibodies. This sounds like tweaking the immune system itself.
That's exactly what it is. This is the heart of modern immunotherapy, especially checkpoint inhibitors. The idea is that T cells can recognize and kill cancer, but tumors evolve ways to put the brakes on that immune response. These antibodies release those brakes.
Cutting the brake lines on the T cells.
That's a good way to put it. The two main brakes targeted are CTLA-4 and PD-1/PD-L1. Ipilimumab blocks CTLA-4, which normally dampens T cell activation. Blocking it unleashes the T cells. It was the first drug to really prove this purely immunoregulatory approach could work.
And PD-1, PD-L1 inhibitors.
Drugs like nivolumab, pembrolizumab, anti-PD-1, and atezolizumab, anti-PD-L1, block the interaction between PD-1 on T cells and PD-L1 often found on tumor cells. This interaction normally tells the T cell to back off. Blocking it allows the T cell attack to proceed. These have had broader success across many cancer types.
And this is where tumor mutational burden, TMB, comes in again.
Yes. It was observed these drugs work better in tumors with lots of mutations, like melanoma or smoking-related lung cancer, or those with DNA repair defects. The thinking, now confirmed, is that more mutations create more abnormal neoantigens for the T cells to see. This led to those tissue-agnostic approvals based on high TMB or MSI status. Really cool biology driving clinical practice.
What about older immune approaches like vaccines or cytokines?
They're generally less specific. High-dose IL-2 can activate immune cells and cause durable remissions in a few melanoma kidney cancer patients, but it's very toxic. Cancer vaccines have mostly had limited success. Oncolytic viruses injected into tumors show some promise. Drugs like thalidomide, imides modulate cytokines, less central than checkpoint inhibitors now.
And finally, T-cell mediated therapies. RT is the big one here.
Right. The idea comes from seeing the graft versus tumor effect with bone marrow transplant. CAR-T therapy takes a patient's own T cells, engineers them in the lab to express a synthetic receptor, the CIR, that targets a tumor antigen like CD19 on B-cell cancers, grows billions of them, and infuses them back.
So they're specifically programmed to hunt the cancer.
Exactly. They've produced stunning results in refractory leukemias and lymphomas, but they're complex, expensive, and have unique, serious toxicities like cytokine release syndrome, CRS, and neurotoxicity that require expert management. Research is pushing to make them safer and use them in solid tumors, too.
The source also mentions stroma-directed antibodies.
Yeah, targeting the tumor support structure, like anti-VDGF antibodies that inhibit blood vessel growth. It's another angle of attack.
Okay, that covers biologics. Let's cycle back to cytotoxic chemotherapy agents in more detail now. The classic chemo.
Right, these are mostly small molecules, often discovered through screening. They primarily work by messing with DNA structure or function, or disrupting the mechanics of cell division, ultimately triggering apoptosis.
In tumors with faulty DNA repair might be more sensitive.
Yes, that synthetic lethality concept again.
Lab.
If a tumor has a weakness in one repair pathway, hitting another pathway it relies on can be particularly effective. This applies to PRP inhibitors, but also potentially to some standard chemo drugs.
They're grouped into DNA interactive and antimitotic agents. Let's start with DNA interactive.
These directly damage or interfere with DNA. Some work regardless of the cell cycle phase nonspecific. Others are most potent during a specific phase, like S phase, DNA synthesis.
Alkylating agents are a major class.
Phase nonspecific, they stick chemical groups, alkyl groups, onto DNA bases, causing breaks and cross-links that kill the cell. They share common toxicities: myelosuppression, hair loss, infertility, mucositis, and that long-term risk of secondary leukemia.
They have specific quirks, too.
Definitely. Cyclophosphamide needs liver activation and can cause bladder toxicity, need hydration mesna. Efosfamide is similar but can cause CNS effects. Cisplatin is famously tough on kidneys, needs lots of 5V fluids, nerves, and hearing, and causes severe nausea vomiting. Carboplatin is easier on kidneys' nerves but hits the marrow harder. Its dose is based on kidney function. Oxaliplatin, used in colon cancer, causes significant nerve toxicity, often triggered by cold.
Then anti-tumor antibiotics and topoisomerase poisons.
The antibiotics, like doxorubicin and anthracycline, wedge themselves into DNA, generate damaging free radicals, and interfere with topoisomerase II. Doxorubicin is a workhorse drug but has that dose-limited heart toxicity risk. Also causes marrow suppression, hair loss, and is a nasty vesicant if it leaks out of the vein.
And bleomycin is different.
Very different. Causes DNA breaks via free radicals. Crucially, it causes minimal marrow suppression, making it useful in combinations. But its big danger is irreversible lung fibrosis, especially at higher cumulative doses or with poor kidney function.
Topoisomerase poisons target enzymes managing DNA tangles.
Exactly. Topoimerases unwind and rewind DNA. Topo I poisons like irinotecan cause single-strand breaks that are lethal during replication. Irinotecan is known for causing severe delayed diarrhea. Topo II poisons like etoposide cause double-strand breaks. Anthracyclines like doxorubicin also inhibit Topo II.
Next up, antimetabolites.
These interfere with the building blocks of DNA and RNA or get wrongly incorporated, often S-phase specific. Methotrexate blocks folate metabolism needed for DNA synthesis. Leucovorin can rescue normal cells. Kidney function is critical for methotrexate clearance. 5-FU and its oral prodrug capecitabine blocks thymidine synthesis and gets into DNRNA. Cytarabine, RSC, gets into DNA, key for AML. Gemcitabine is similar but used more in solid tumors.
Purine analogs, too.
Like 6-mercaptopurine interacts with allopurinol. Fludarabine causes significant immune suppression. Cladribine, active in hairy cell leukemia.
And asparaginase is unique.
Very. It's an enzyme that breaks down the amino acid asparagine, which some leukemia cells can't make themselves, starves them, can cause allergic reactions, pancreatitis, clotting problems.
Lastly, for cytotoxics, the mitotic spindle inhibitors.
These target microtubules, the protein filaments forming the cell's skeleton and the spindle needed for mitosis. Vinca alkaloids like vincristine cause microtubules to fall apart, blocking cell division. Vincristine is known for nerve toxicity but spares the marrow. Taxanes like paclitaxel and docetaxel do the opposite. They stabilize microtubules, freezing the spindle, also blocking division. They cause marrow suppression, nerve damage, and sometimes hypersensitivity reactions.
Incredible variety just within the cytotoxic category.
Mm.
Now let's revisit cancer molecular targeted therapy in more detail.
Right, these are aimed at specific molecular drivers. The oldest type is hormone therapy, targeting the estrogen receptor in ER plus breast cancer with tamoxifen or aromatase inhibitors, targeting the androgen receptor in prostate cancer with blockers or drugs inhibiting androgen synthesis.
But most targeted therapies now hit kinases.
A huge number do. Kinases are those molecular switches controlling cell growth, survival, etc. Cancers often have mutated or overactive kinases driving them, so you have inhibitors for abelkinase and CML, imatinib and newer agents, EGFR, ALK, ROS1, RATE-BRAF, or FLI-F in lung cancer, drugs like osimertinib, alectinib, sulpercatinib, dabrafenib, trametinib, HER2 in breast and gastric cancer, trastuzumab, pertuzumab, newer small molecules like tucatinib, KIT ingest, imatinib, sunitinib, JA kinases in myeloproliferative disorders, ruxolitinib, BTK in B-cell lymphomas CLL, ibrutinib, and others.
And resistance is a big issue, leading to next-generation drugs.
Absolutely. Tumors mutate the target kinase to evade the drugs. You need drugs that hit the mutated form, like osimertinib for T790M mutant EGFR or ponatinib for T315I mutant BCR-ABL.
There are also multi-kinase inhibitors hitting several targets.
Yes, drugs like sunitinib, sorafenib, pazopanib, lenvatinib used in kidney cancer, liver cancer, thyroid cancer, sarcomas. They hit multiple pathways but often have broader toxicity profiles.
What about targeting the cell cycle directly?
CDK46 inhibitors, palbociclib, ribociclib, abemaciclib. They block progression into DNA synthesis. Very effective in hormone receptor-positive breast cancer, usually combined with hormonal therapy.
And targets involved in protein handling or avoiding cell death.
Proteasome inhibitors like bortezomib are key in multiple myeloma, disrupting protein breakdown. Venetoclax targets BCL2, an anti-apoptosis protein used in CLL and AML. Exportin-1 inhibitors like selinexor affect protein transport from the nucleus.
The source also details chromatin-modifying epigenetic modulators. Sounds complex.
The idea is to change gene expression without changing the DNA sequence. Hypomethylating agents like azacitidine remove methyl tags that silence genes used in MDS and AML. HDAC inhibitors like vorinostat alter how DNA is packaged by histones used in T-cell lymphomas. Newer agents target specific histone-modifying enzymes.
In targeting cancer metabolism.
Cancers often rewire their metabolism. mTOR inhibitors, everolimus, and PI3 kinase inhibitors, alpelisib, idelalisib, hit key metabolic signaling pathways. IDH inhibitors, ivosidenib and asatinib, target mutant metabolic enzymes in certain leukemias and other cancers, which indirectly affects epigenetics.
Finally, DNA repair pathway modulators, PRP inhibitors again.
Exactly. Olaparib, niraparib, etc. They exploit the synthetic lethality concept in tumors with homologous recombination defects, typically due to BRCA mutations. By blocking PRP repair, DNA damage becomes lethal, used in BRCA mutant ovarian, breast, prostate, pancreatic cancers.
It's incredible how targeted things have become. What about systemic radiation therapy? Delivering radiation via IV.
Yes, using radioactive isotopes. Classic example is radioactive iodine for thyroid cancer. The thyroid selectively takes it up. Other isotopes like samarium or radium target bone metastases, or you can attach isotopes to antibodies like Y90 ibrutinib texetan for lymphoma, or ligands like Lu-177 dotatate for neuroendocrine tumors to deliver radiation specifically.
With all these powerful tools, resistance is the constant enemy. How do tumors fight back?
It's complex and multifaceted. For conventional chemo, we've known for a while about mechanisms like tumors learning to pump the drug out using proteins like P-glycoprotein, or changing enzymes to metabolize the drug faster, or making more of the target protein or mutating the target.
So the cell actively defends itself against the drug.
Right. Another layer is resistance through changes in the cell's basic biology, especially losing the ability to undergo apoptosis when the drug hits its target. The cell just becomes insensitive to the death signal.
And for targeted therapies, it's often mutations in the target itself.
Very common. The kinase gets a mutation so the inhibitor drug can't bind anymore. This ties directly into tumor heterogeneity. Tumors aren't monolithic, they're collections of different subclones with different mutations.
So treatment kills the sensitive clones, but resistant ones survive and take over.
Exactly. That's why the source suggests the most durable targeted therapies hit something all the subclones need, a fundamental dependency. If only some clones rely on the target, resistance is almost inevitable.
Which explains combination therapies and sequencing treatments.
It's an evolutionary arms race. The tumor adapts, we adapt our strategy.
Okay, last major section. Supportive care. Managing side effects is non-negotiable, right?
Absolutely critical. You can't deliver effective treatment if the side effects are intolerable or dangerous. Supportive care enables patients to get through treatment safely and maintain quality of life. Myelosuppression is a huge role.
Damage to the bone marrow from cytotoxic chemo.
Right. It limits the tolerable dose. Neutrophils, infection fighters, drop first and fastest, increasing infection risk. Platelets, clotting, drop next, increasing bleeding risk. Red cells, oxygen, drop last, causing anemia and fatigue.
How are these managed?
Neutropenia risk can be reduced with growth factors, CSFs like G-CSF, to boost marrow recovery. Thrombocytopenia might require platelet transfusions if counts get very low. Anemia is managed with red blood cell transfusions. Use of EPO to stimulate red cells is more controversial now due to some concerns about tumor effects.
Nausea and vomiting, the classic chemo side effects.
Still very common, but much better managed now. We classify chemo drugs by their immunogenic risk, high, moderate, low, minimal, and use combination antiemetics preventatively, especially potent serotonin 5-HT3 antagonists and NK1 receptor antagonists, often with steroids. Getting nausea control right is vital.
Mucositis, that painful mouth and gut inflammation.
Can be debilitating with certain regimens. Affects eating, swallowing, good oral hygiene, topical anesthetics help. Palifermin can prevent severe mucositis in high-dose settings like stem cell transplant.
Hair loss, alopecia.
Highly variable by drug, but psychologically very difficult. Some drugs cause complete loss. Good support and cosmetic options, wigs, scarves, are important. Scalp cooling is an option, but sometimes debated in curative settings.
And the impact on fertility and pregnancy.
Major considerations. Chemo can harm a developing fetus, especially early on. Decisions about treatment during pregnancy are complex. Many agents, especially alkylators, cause infertility by damaging ovaries testes. Sperm banking for men, embryo freezing for women are options but need discussion beforehand. Fertility recovery is less likely with age. Contraception during and after treatment is essential.
Finally, the source addresses palliative and supportive care in the advanced setting.
Yes, when cure is off the table, the focus shifts entirely to comfort, symptom control, and quality of life. This involves expert management of pain, nausea, fatigue, shortness of breath, etc., plus addressing psychological, social, spiritual needs of the patient and family.
Sometimes patients still want aggressive treatment, even when it won't help.
That can happen. It underscores the need for honest conversations about prognosis and goals and the importance of palliative care specialists and hospice in providing the best possible support and ensuring patient choices align with realistic goals focused on comfort and dignity.
Wow. We have covered an incredible amount of territory in this deep dive. It's really quite something.
It really is. From the very start, considering cancer, through the intricacies of diagnosis, staging, understanding growth,
To the history and the sheer diversity of treatments. Local, systemic, cytotoxic, targeted, biologic, immune.
and the mechanisms, the molecular details, the constant battle with resistance, and the absolute necessity of supportive care.
It paints a picture of cancer treatment not as a single thing, but as this dynamic, incredibly complex, multidisciplinary field that really leverages deep biological understanding.
Exactly. And it highlights both the amazing progress we've made and the significant challenges that still remain. Achieving that elite professional understanding requires grasping all these interconnected principles.
It really does. So thinking about this constant evolution, this back and forth between the tumor adapting and researchers finding new ways to attack, what do you think might be the next really big shift? Where do we go from here, building on everything we've just unpacked? Is it even more precise targeting, combination immunotherapies, maybe predicting resistance before it happens, or something completely different? Definitely something for you, the listener, to think about.